Evening, everyone. My name's Shaba Jaffer. I'm the director of the UCL Institute for Global Health, and it's actually my great pleasure to welcome you all here, welcome you to UCL, welcome you to the UCL-Lancet Lecture. This is actually a joint venture between IGH and UCL Grand Challenges and the Lancet Journal. We've been organizing these lectures since 2001. This year, the topic is very dear to my heart, and so I'm very much looking forward to it. After the lecture, there will be a question and answer session, and I welcome you to submit questions via Slido by scanning the QR code. One really key thing that I want to do also is to thank all those involved. Now, I'm not actually allowed to name people individually because I might forget someone, but in particular the team at the Institute for Global Health and Professional Services team, the Grand Challenges team, and the events team, and the team at the Lancet. Big thanks to all of them for organizing this, and to the student ambassadors, the catering, the audiovisual, and video teams. So with that, I'm going to, and also a big thanks to the Lancet for co-supporting this event. And with that, I want to introduce the event chair, who's Dr. Richard Horton, the chief editor of the Lancet. Richard.
Thanks so much, Shaba. Thank you so much for coming. You could be sitting at home watching this with a glass of something in your hand, but you took the effort to come tonight, and we're extremely grateful. May I reciprocate the words of Shaba about the importance we attach to our partnership with University College London, which continues to give an important platform to some of the most talented scientists and scholars in the country, indeed the world. We share many values together, but at this time of conflict on campuses in many countries, and when governments seek to impose direct and indirect limits on freedom of the press, it's our shared commitment to academic freedom, to independent critical thought, and to opposition to censorship that unites us and must continue to unite us in the future if we are to preserve the fragile liberties that underpin our precious democratic traditions. Professor Linda Villarosa, our speaker this evening, is based in New York. She is a journalist, an author, an editor, a novelist, and an educator. She's a graduate of the University of Colorado and spent a year at the Harvard T.H. Chan School of Public Health as a journalism fellow. She graduated with a master's degree in urban journalism and digital storytelling in 2013 from SUNY's Craig Newmark Graduate School of Journalism. She's currently serving as a professor and journalist in residence at the City University of New York, where she teaches journalism, medicine, and Black studies, also at the City College of New York in Harlem. In her current role as a contributing writer for the New York Times magazine, Professor Villarosa covers topics related to race, inequality, and health. She covered the impact of COVID-19 on Black communities in America. As a journalist, Professor Villarosa has held editorial roles for the health pages at the New York Times and has been the executive editor for Essence magazine. Throughout her distinguished career, Professor Villarosa's writing has received awards from organizations such as the American Medical Writers Association, the New York Association of Black Journalists, and the National Lesbian and Gay Journalists Association. Additionally, Professor Villarosa uses her expertise to train journalists across the world to better cover the HIV/AIDS epidemic at international AIDS conferences. She's an accomplished author, as you all know, and she's authored and co-authored 3 books, including Body and Soul, The Black Women's Guide to Physical Health and Well-Being, Passing for Black, the latter earning the Lambda Literacy Award nomination. Her latest work is an absolute must-read, and you need to go out and buy it immediately after this lecture if you haven't already. It's entitled Under the Skin, The Hidden Toll of Racism on American Lives and on the Health of Our Nation. And it deservedly received acclaim as a 2023 Pulitzer Prize finalist and was featured in the New York Times 10 Best Books of 2022. Last year, a team of American scientists reported research in Science magazine seeking to identify what kind of information could trigger public support for reducing racial disparities. And the answer was health. Health inequalities adversely affecting Black Americans elicited greater support for political action than, for example, economic disparities. Why? Because health was seen to have a morally sacred value and place in our vision for what is or is not a fair society. So all the more reason to listen to Professor Villarosa most attentively as she delivers the annual UCL-Lancet Lecture, Under the Skin, Understanding the Toll of Race and Inequality on the Health of People. Please give Professor Villarosa your warm welcome.
Thank you so much. Thank you for that introduction. I felt like, who is that person that sounds so wonderful? I am so glad to be here. I'm honored to deliver the lecture, the UCL, the Lancet. The Lancet is a valuable resource for me. I'm just getting to know this university, and it's wonderful, beautiful, and all of you people look really great to me. I love it here. And just putting it out there that if there's any invitation for me to be like a temporary lecturer here in this beautiful city, there I am. I'm going to start with this quote. And for someone like me that gives a lot of talks in February during Black History Month, this quote comes up a lot. Of all forms of inequality, injustice in healthcare is the most shocking and inhumane. This was delivered by Dr. Martin Luther King in March 1966. In 2018, a professor from Wellesley went and actually looked back at this speech and found that it's not correct this way. What Dr. King really said is that of all forms of inequality, injustice in health, not healthcare, but health itself, is the most shocking and inhuman. And inhuman is worse than inhumane, and health is more expansive than just healthcare. So these are the ideas I want to touch upon in this lecture. America is the wealthiest nation in the world, and we spend more on health care itself than any other country, $12,000, over $12,000 per year per person. Here you spend about $5,500 a year, but we spend a lot. Still, money doesn't buy good health in the United States. Compared to other wealthy countries, we have the highest rate of infant and maternal mortality. Among the healthy countries, we have the lowest life expectancy and the highest rate of avoidable death. And then among the wealthy countries, we, especially at the beginning, had the highest death rates from COVID-19. And when I talk about this, it's often presented as a mystery. Why, if the US is spending so much money, is so rich, that we're getting such poor health outcomes? But it's really, if it's a mystery, it's hiding in plain sight. First, our healthcare system is based solely on capitalism, the ability to pay. So if you, unlike here, so if you cannot afford healthcare, sorry for you, mainly in the US, still, and universal healthcare should be a human right. However, in America, even if every American had access to healthcare, we would still have many of the same problems. And you heard that I grew up as a young journalist at Essence magazine, a magazine specifically targeted for Black women. At its heyday, when I was there, we had 1 million subscribers and 8 million readers. And so I really dug deep into the health and wellness of Black people. And that's what my book focuses on as well. Black Americans, just to put it simply, live sicker and die quicker than anyone else in our country. And that starts at the beginning of life and it goes all the way to the end. First, a Black baby is about 2.5 times more likely to pass away before the age of 1 compared to a white baby. And it's also the highest rate of all the races. A Black birthing person is 3 to 4 times more likely to die or almost die just being pregnant and having a baby. Black people have the lowest life expectancy compared to other groups. We now live 6 fewer years than the average white American. It used to be 3.5 years, but after COVID and the disparities that happened during the COVID-19 pandemic, the gains we had made in life expectancy went away and it got worse. But the long-standing explanations of what is causing racial disparities among Black Americans are 2 things: poverty and lack of access to health care alone. We'll start with poverty. Clearly, poverty is terrible. It causes disruption. It causes communities to lack wellness. It causes fear and scarcity. But it isn't the only reason Black people have poor health outcomes. These are current rates of poverty by race. So about 18% of Black people live under the federal poverty line in 2022. Now I'm going to tell you how old I am so that you can know that in 1959, when I was born, the poverty rate was inching toward 60%. So 60% of Black people were poor when I was born. After the civil rights movement in the 60s and early 70s, that rate plummeted to about 40%. And now it's 18%. But even though the poverty rate has gone down and there's been a rise of a robust Black middle class, you have not seen an equal narrowing of the health outcome gap. And in fact, a Black birthing person is more likely to lose her baby now than 20 years ago. And the disparity is wider than in 1850. The Black-white racial disparity in infant mortality is wider than in 1850 when Black women were enslaved. So something is wrong. This is not just a question of poverty. This is the slide. These are the statistics that really got me going and got me to write my cover story in 2018, Why America's Black Mothers and Babies Are in a Life or Death Crisis. A Black birthing person with a college degree is more likely to die or almost die than a white woman with an 8th grade education. So this has nothing to do with poverty. And education, especially a higher degree, and the degrees, it counts for a master's degree, a PhD, an MD, a JD, should give you access to everything to keep you healthy during your pregnancy, during childbirth, and in the time after. But somehow this happened. And the disparity is worse at the more educated end. I have a friend who's a physician, and she graduated from Black physician, graduated from Harvard Medical School, and she gave me the statistic that a Black educated woman who is even a physician is 5 times more likely to die during pregnancy and childbirth than her white counterpart with the same level of education. And last year, a study, I read it in my own newspaper, the New York Times, really stood out to me. The New York Times is super serious, and so we do not usually use the word rich, okay? But this was the headline. We use wealthy or wealth. Childbirth is deadlier for Black families even when they're rich. So that is saying something. That's saying this is not just a question about poverty. This is not just a question about lack of access to health care. It is something else. So if it's not those two things, then the knee-jerk reaction or the knee-jerk explanation is it's something different about Black people's bodies that is causing a problem, or it's something different about Black people and our culture that is to blame. So are Black people genetically different as a demographic than others? That is a rhetorical question. The answer is no. Just checking. But physiological differences that still exist in modern medical training and practice almost always mean inferior. And some of them are based on stereotypes that were left over from the years of enslavement used to justify slavery. So I'm going to cover 2 myths that still exist but come all the way back from 400 years ago. This is the myth that Black people have inferior lung function. For the 1619 project, I traced this back to Thomas Jefferson. He wasn't a scientist, not a doctor, the 3rd president of the United States, author of the Declaration of Independence. All right, in Notes on the State of Virginia, which he wrote in 1785, it wasn't about slavery, it wasn't about Black people, but there were a few offhand comments about racial inferiority of Black people, including myths about physiological differences and including that Black people had weak lungs. What's ironic is that the woman here is he was his slave who he had 6 children with. So he was busy talking about the inferiority of his own children. It's very difficult to read Notes on the State of Virginia, but many people read it. It was a treatise. It was very, very influential at the time. No one grasped onto these theories more fervently than Dr. Samuel Cartwright. And he was an expert in Negro diseases. And I don't even know where to put the quote marks. It's like expert, Negro, disease, I don't know. But Dr. Cartwright that was his expertise. He also owned enslaved people. He had a plantation. But he was the go-to person to talk about problems of Black people. He was educated and taught at what is now Tulane University in New Orleans. He was published in medical journals. He was very, very well regarded. But here are some of the things he said. He claimed that Black people were different physiological, had smaller brains, more sensitive skin, overdeveloped nervous systems, as well as weak lungs. He also created this mental illness, which he called drapetomania, and it was an illness that caused Black enslaved people to want to run away. It sounds so deranged now, but this was codified. It was in a medical journal. It was introduced at a medical conference. So at the time, because he was an expert in this area, people believed him. He also was one of the first people to use, if not the first one, to use a spirometer to measure lung function. And given he was using the spirometer and he had it calibrated with the assumption that Black people have 20% less lower lung function, and that working in the fields as enslaved people caused vitality to the blood and helped build strength, lung strength. So I know it doesn't sound right to us in modern day, but this through line continues to today. The modern spirometer is calibrated, the calculation is calibrated not with 20%, but with a 10 to 15% assumption that Black people have lower lung function. And I was thinking about this. You heard from my introduction that I'm from the state of Colorado, and I'm from Denver, which is the Mile High City. The air is very, very thin there. So you have to have really good lung function. If you're like me, you run track. So I think of myself as having the lung function of Serena Williams. So it is not right medically or in any way for me to go have a lung function test with this spirometer calculating that I have 10 to 15% lower lung function. That is just bad medicine left over from an incorrect assumption. All right, the second myth, more insidious in many ways, is that Black people have superhuman tolerance to pain. I show this picture. This is the Legacy Memorial in Montgomery, Alabama. And if you ever get to the United States, please visit Montgomery, Alabama and see this wonderful museum and memorial. But this is a picture from it. This is J. Marion Sims. He is, I now added so-called, long considered the father of modern gynecology. That is the Sims speculum, which he invented. He practiced in Montgomery, Alabama, and he found a cure for fistula, which many of you know, is an extreme side effect of pregnancy. But what he did was he practiced on 3 enslaved women, Anarcha, Betsy, and Lucy. And this, when his medical breakthrough is discussed in proceedings, in books, it often is accompanied with this painting. And this painting is false. In his own biography called My Story, he described the pain that Anarcha was on the table, nude, being held down by the other 2 women. And he, even though he could see for himself that this woman, this enslaved woman, was in pain, there was a disconnect because of this myth that Black people don't feel pain in the same way. Fast forward to today. This is a survey from 2016. There have been others, but this one was the most defining. And it asked medical students and residents from the University of Virginia about myths about Black people's bodies. Nearly 50% believed at least one of the myths, including the idea that Black people have thicker skin, some of the very ideas that Thomas Jefferson was espousing around nerve endings, but also that Black people had higher pain tolerance. So this is scary if today's medical students and residents still believe myths that came from so long ago, from the days of enslavement. But pretty much finally, the idea that Black bodies really are not different as a demographic, everybody's body's different, but as a people, our bodies are not significantly different from other races. So this study was really important. And it was looking at low birth weight and infant mortality, because at the time, the first round of this study came in the 90s. This is the second round, which really blows it out. But it was in the New England Journal of Medicine, and I was reading it with great interest, because at the time, it was believed that infant mortality was due to a Black gene, that there was an infant mortality gene that Black people had. So 2 perinatologists in Chicago set out to prove this wrong. And what they did was looked at tens of thousands of birth certificates of 4 groups of people. The first group, so it was 2 immigrant groups and 2 groups of Americans. So it was Black American birthing people, white American birthing people, new immigrants from Europe, and new immigrants from Africa. And so what they were looking at is how were the, if it was a Black issue, how did the Black immigrants compare to the Black Americans? So the first round of looking at birth certificates and looking at the birth weights, 3 groups were basically the same. The 2 white women groups and the Black immigrants from Africa. Only the African American women's babies were significantly smaller. So then they went back and looked at the birth certificates of the people who were female and had a baby. And in one round of, one generation, now the European babies from the European immigrants were slightly bigger. The white American babies were the same basic birth weight. The Black American babies were still smaller. And now, in one generation, the babies from the poorest countries of Africa were now also smaller, even though they had started out. So they matched the African American babies. And what intrigued me about this study was the quote that came with it. For Black women, something about growing up in America seems to be bad for your baby's birth weight. Dr. Richard David said that. Dr. David is not some wild and crazy activist. He is a very serious person. I often visit him when I'm in Chicago, and he was surprised by this, and he was even surprised that, this is pretty radical to say in a medical journal, but I really appreciated his bluntness, and it really put an end to this discussion about some kind of infant mortality gene. All right, if it's not genetics that is the problem of racial inequality in health outcomes, then it must be something that Black people as a whole, that we're doing something wrong, we lack education, don't know what to do to take care of ourselves, or don't care. Of course, individual behavior is important. I have to always remember to say that from my Essence days. Of course, you want to drink a lot of water, you want to take care of yourself, you want to get a lot of sleep, you want to exercise, but individual behavioral change will not significantly shift the racial health outcomes of Black Americans as a people. However, that idea that if we just knew better, we would do better is also old. It's from stereotypes left over from enslavement, meant to dehumanize people, meant to boost up the American economy by providing free labor. All right, so this is a stereotype of Black women. This is Serena Williams. This is her in her US Open game. She was actually playing against Naomi Osaka. Thank you for that correction. And this cartoon ran with it. And this cartoon is offensive, but it's making Serena Williams, who is a fierce, intense, smart, emotional player, look crazy and look out of control, look hostile, look scary. And that is a stereotype. And that cartoon was widely considered offensive. But that stereotype has a price. When Serena Williams, this is her with her first baby, who she had in 2017, and she went to the hospital. Clearly, she's rich, she's married to the founder of Reddit, he's rich, so there wasn't a problem of lack of access to health care or poverty. She goes into the hospital, she's pregnant, she knows she has a history of blood clots, but she's taken off of her anticoagulant medication to have her baby. So then afterwards, she felt herself short of breath. So she tried to explain her legitimate concerns to the medical staff, and she was shut down. She was quite short of breath and started coughing quite hard. She had an emergency C-section in the first place. The stitches broke through, and they found a hematoma in her abdomen. Thank God, they saved her life, but she was trying to tell them what was going on, and they weren't listening to her. She spent 6 weeks in recovery, and what was supposed to be the best day of her life turned into one of the worst. And she's written about this pretty widely. She's had another baby. This baby is fine, but still, even Serena Williams wasn't listened to, and her her legitimate concerns were ignored. And part of it is because of the stereotype is when you're a Black person, a Black woman, you speak up for yourself, you are read as angry. This is Dr. Susan Moore. She was a physician in Indiana. She graduated from medical school there. She practiced in Indiana. In 2020, she got COVID and went into the hospital system in the city where she works. She was short of breath and also had pain in this area of her body. She explained these concerns to the providers taking care of her. She used medical terminology because she was a physician. She spoke up for herself and she was shut down. She said herself that she was treated as though she were not sick, but that she was drug seeking. The picture of her with the tube in her nose is from a Facebook video she recorded on her phone of herself, talking about the poor treatment she received. And throughout, she said, "This is how Black people get killed." She got out of that hospital, and a few weeks later, she died. In the investigation of the hospital system, one of the things they found that her care was lacking because some of the providers taking care of her were intimidated by her medical knowledge. So I submit to you that her, as a physician, trained in the system, just trying to advocate for herself in the way we should, she was read as angry, she was shut down, she was ignored, and this is how Black people get killed. All right, so the newer explanation is not that something is race, something's different about the Black community, or something's different about individual Black people's bodies, but that the problem is racism. It is ill treatment that causes poor health outcomes. So my book explains it in 3 ways: that battling discrimination and bias creates wear and tear on the body and a kind of premature aging. Centuries of sanctioned discrimination has made Black communities less healthy. And then racism in the medical system itself harms Black people. And each of these 3 contentions I have a personal experience with which I'd like to share. So first, the lived experience of discrimination is often called weathering. That is a term coined by Dr. Arlene Geronimus, who is a professor at the University of Michigan. And it talks about how when you are treated badly, whether it's a so-called microaggression, it's everyday racism, or it's by the police in housing or at your job, your body, the systems of your body change. So each time it happens, your allostatic load rises and goes into overload. So you get upset, your body tenses, your heart rate goes up, your body is flooded with stress hormones, your blood pressure goes up, and that is fine, fight or flight, sometimes. But if it happens over and over, it creates a kind of accelerated aging. And Dr. Geronimus studied it in infant mortality because it comes up during pregnancy and childbirth, which is already a kind of stress test. Before COVID happened, Dr. Geronimus was not largely believed, but after COVID showed that Black people got worse health outcomes at younger ages, suddenly the idea of Black people and other people of color, or anybody who's discriminated against, experience a kind of accelerated aging. Now it's caught on. And she actually has a book. She was like, I'll never get a book. And she has a book, it's published, it's called Weathering. I suggest you pick it up, it's quite good. All right, this is personal to me. This is my family. That's me looking exactly like a knockoff of my father in 1968. And my family had lived in Chicago until I was about 9 or 10 years old. And then my parents decided we need to get out of Chicago. We lived here our whole lives. They wanted a place that was safer for us with better schools. and with beautiful outdoors. So my parents went ahead, they bought our house in suburban Denver. And we packed up, they came home, they said, we're taking off. We packed up the car and we drove across country from Chicago to Denver. And my sister and I, both of us remember how excited we were because we were gonna get our own rooms, we were going to a new school, everything was gonna be great. As we drove up, we saw the house and someone had written N-word, go home on the garage in big, horrible letters. My father said, we're out. We're going home. We are not staying in a place we're not welcome. My mother suggested that we stay and convinced all of us to stay. It turns out it was the two boys, they were twins, that lived not next door but the door down, that had done it on a dare. And their punishment was that they had to deliver our newspaper free for a month. My punishment was that I had to live with them and go to school with them, you know, all through elementary school, junior high, and high school. And I think about this a lot, and I thought about it when I had my own baby. That's Callie. You can tell she is totally fine now, but she was born at 4 pounds, 13 ounces, which is considered low birth weight. I, of all people, did every single thing right. I was the health editor of Essence when I was pregnant. I was super careful. I had a really great doctor. I didn't have problems until labor. And then, well, a little bit before, I had intrauterine growth restriction. I was on bed rest for a while. Then I had a really touch and go labor. And after my daughter was born, she could fit in the palm of my hand. I'm so glad she's athletic and healthy and smart and wonderful. But I always thought, how much was I weathered, given that early experience in Denver and throughout being the only Black person in most of my schools and classes? I thought about that. I'm only a petri dish of one, but weathering, once I understood it, felt personal to me. Weathering, I asked Dr. Geronimus, we were having breakfast, and I said, is weathering just a Black thing? Is it just happen to Black people? And she said, no, it can happen in any oppressed group. And she broke it down with an example that happened in 2008 in Postville, Iowa. And there was the largest, at the time, ICE raid of a company. It was a meat packing company that had a lot of Latinx people working there, immigrants. Some documented, some undocumented. And this was a terrible raid. It broke up families, people were incarcerated, people were hiding out. It was really scary. It disrupted this whole community. Dr. Geronimus went in and looked at birth certificates a year after, and the birth certificates of Latinx people, even those who were not directly involved in the raid, were 25% less. So the birth weight of the community changed after this really terrible, disruptive moment in time. And she said, always remember to think marginalized and oppressed groups, it's not only Black people. And I appreciated that. All right, so the second, well, I know everyone here knows what the social determinants of health are. I would make just a mild suggestion that maybe it's time to change the name. It's a little wonky, but what it is the communities where people live and work, play, pray, and it has to do with how you live. Communities of color, we know, usually live in, are situated in communities with poor social determinants of health. And the biggest, it's about the environment, and often the environments are polluted. Black people in America are 75% more likely than others to live near a polluting facility, whether it's an incinerator, a landfill, a refinery, or a garbage dump. And that is because of centuries of discrimination. That is personal to me as well. My family, my grandparents and all their siblings came during the Great Migration, which brought 6 million Black people from the South to the North. It brought 500,000 to Chicago, and my ancestors were among them. My grandparents are in that picture. That's me sitting on my grandfather's lap. And they came with they brought their money. They had been farmers in Mississippi, came to Chicago ready to buy a home. And at the time, the Black communities of Chicago were redlined, which meant literally there was a line drawn around the Black communities, which meant they were given a hazard rating. If you had a low hazard rating, ABCD, then it was hard to buy a home because you couldn't get a mortgage. Banks wouldn't lend to you. So what happened was contract buying swooped in, and contract buyers would charge you more for the home. Contract buyers would charge you higher interest rates if you could, but you really couldn't get a mortgage. You had to buy on equity. You never really outright owned your home, so you were always afraid of losing it. That picture of, I show that because that made a difference to this community that was a promised land to 500,000 new immigrants. People lived to age 60 in current day. Black people, people in Inglewood, which is a Black community, lived to only age 60. 9 miles north, they lived to age 90. It's the widest life expectancy gap in the country, 30 years and 9 miles. My mother and I went there in 2020 because she wanted to see what was going on in Chicago. And I told her about this life expectancy gap. I said, Mom, that's where you grew up. So she was really proud that she went to Inglewood High School. So we went to Inglewood High School, it was closed. So then she said, I'm especially proud that I went to Betsy Ross Elementary School because that's the lady that made the flag. She went there with Lorraine Hansberry, who wrote Raisin in the Sun, Gwendolyn Brooks, who was a prize-winning poet. So we go to the elementary school, and that's a picture of it. That's my mom a couple of years ago. It was completely boarded up. Most of the area that she was so proud of, where our ancestors were from, what looked like rural Mississippi. So much of it was just vacant land or boarded up buildings. So if a community doesn't have wealth, it can't prosper and it can't have good health either. And that's what the social determinants of health really mean to me. The third problem is discrimination in the healthcare system itself. And sometimes I get on panels where it's like me, and then there's like Dr. So-and-so and Professor blah, blah. And well, I'm Professor too. PhD so-and-so, Dr. so-and-so. And we're talking about these issues. And the last time it happened, I was at a very fancy medical school, and Dr. so-and-so and Professor so-and-so both said, we just need more evidence of discrimination in the healthcare system. I did not want to embarrass myself at fancy medical school, so I did not get angry, but I did get a little testy, and I said, we need no more evidence. If you do not believe the 483 studies in unequal treatment, which was a government document released in 2003 and is now being redone, it'll be out this summer, then I don't know what else you need. We need no more evidence that there is discrimination in the healthcare system itself, and it's been codified. Now, I am a nerd and looked at all 483 studies. So I want to point out one to you that's the most disturbing, and it was about amputation and diabetes. So it looked at Black patients and white patients who had equal levels of access to healthcare and also had equal severity of diabetes. However, the Black patients were 3.6 times more likely to get an amputation. So I don't think people go into being healthcare providers to do harm. In fact, you know, the very saying is do no harm. But something is going on in our system that is harming people. This is personal to me. This is, again, my father. In 1999, I was pregnant again, and I was working at the New York Times newspaper. Living in New York, my mother was still in Denver. My mother called me on the phone, kind of hysterical, and she said, you need to come home now. You need to get on a plane, you need to put on your best clothes, and you need to put your New York Times business cards in your pocket. And I said, why? What's happening? She said, your father is much sicker than he's let on, and he's in the hospital, and you need to come and help me. So I did it. I got on the plane, put on the suit, put the business cards in the pocket. My mom greets me, picks me up at the airport, and I said, Mom, please explain to me what's going on. And she said, your dad's in the hospital, they're treating him like an N-word, the same word that was on our garage door. We go to the hospital, and my father was an extremely well-dressed person. He was really fastidious about his appearance. He was trained as a bacteriologist, so he's a scientist. He has a scientist's brain. He's really nice. He's very patient. He loves fishing. Fishing's boring if you're not catching, so he's like a very patient person. I mean, it really is. And I even like it. He had a really good sense of humor. I walk in and I see him looking completely disheveled. He's totally angry. He's really, really upset. And then I leaned down and I saw that he was restrained to the bed. And I was in shock. And my mother said, okay, this is worse than I thought. So we went home and we got pictures like these of him as, you know, in the service. We said he served his country. We got pictures of him in his nice suits. We explained to him that he's trained as a scientist. We talked about that he's a patient person, but if you don't explain things to him, he is going to get agitated and he's going to appear angry to you. I never forgot that. My father was quite ill and he died not that long after, but I never forgot the idea that why did we have to go to get my dad out of that hospital? Why did we have to dress up? Why did we have to pull this respectability card? Why did we have to show he was middle class and educated? He should have gotten fair treatment like anyone should get. So these experiences, these personal experiences have really informed my thinking and my work. On the plus side, finally, I was really excited about, in California, the SB 464, California Dignity in Pregnancy and Childbirth Act, was signed into law in 2019. California had the same kind of maternal mortality problems that the rest of the country had, where the rates were rising, Black women were 3 to 4 times more likely to die. It was a problem. Why in our country do we have rising rates of maternal mortality? So what they did was put into place protocols. They realized that at hospitals in California, if there was an obstetric emergency, mainly an emergency C-section like Serena Williams had, or preeclampsia, that all of the tools weren't on hand and all of the protocols weren't in one place. So they did it. They put those things in place and then they studied it over a period of time. And sure enough, by making changes at the hospital level, the maternal mortality rate of the state of California dropped 55% in 6 years. But what didn't change at all was the racial disparity. Black women, even though, you know, everything else dropped, were still 3 to 4 times more likely to pass away having a baby. So what they did in California was say, we can't doctor our way out of this problem. What we need to do is demand that and put into law this act, which includes that anyone working with a birthing person, a pregnant person, or the time after helping someone breastfeed, must go through some kind of implicit bias training. I do not think implicit bias training is the be-all, end-all cure, but at least it's something. We don't know how well this worked because obviously in 2020, things changed and the maternal mortality rate ticked back up because of an overload of the system and other problems. But keep an eye on California to see what happens, to see if this actually worked. I am really proud to do a lot of speaking at medical schools. And I see a generation of medical students that are really engaged, that are very interested, energized to talk about health inequality, to talk about the way they want to be physicians, nurses, doctors, midwives, or to go into public health. And it's been really exciting and energizing for me to have access and to have conference and discussion with medical students. This is really specific. It's called the Institute for Healing and Justice in Medicine. This is look it up online if you can. It's a really wonderful group of medical students who started a group to talk amongst themselves. They have Zoom meetings to talk about changes they want to make at their own medical schools and in medical practice. They're very good. I sometimes sit in on their meetings. I find them very smart, and they wrote a manifesto about this that looks a lot like my book. It's so good. First I was kind of like, uh-oh, I think they've already done it. And I'm like, no, theirs is just a manifesto online. I have a book deal. It's very good. Finally, I'm not finally yet, but doulas, patient navigators, community health workers. When I was traveling abroad, I saw health extension workers, community health workers in other countries that had much less advanced healthcare systems than ours. And they were using them so effectively. And I just thought, why don't we have these why don't we have this in the United States in a coordinated way? They are paid, they're part of the government, they're chosen by their communities to be active healthcare providers. In the United States, we certainly have sometimes community health workers. We definitely have doulas. We have patient navigators sometimes, but we don't have a coordinated system. I've certainly worked with a lot of doulas in my own work, and often they don't get paid, or they get paid such a small amount that it isn't fair. And sometimes they get paid by nonprofit organizations, not by the systems themselves. If we didn't just rely on our medical technology and our medical innovations to heal, and thought about actually having healers as people to connect, put the care in healthcare, that is very important. That is what people are asking for, and these people are doing tremendous work. The other thing that works is activism. This is J. Marion Sims' statue in Central Park in New York, and there was a year of sustained protest against him. When people started to find out about what he had done to Lucy, Anarcha, and Betsy and his experiments, they protested his statue, and it was taken down. So it's not in Central Park anymore. It was across the street from the National Academy of Medicine, which was totally insulting, but now it's gone. However, in Montgomery, Alabama, where he did most of his practice, the statue is still up. So the woman in the red glasses is Michelle Browder. She is a wonderful artist and activist, and she made a counter sculpture garden of Anarcha, Lucy, and Betsy that are larger than life. She has information all throughout her sculpture garden, which is about medical inequality and J. Marion Sims, and tells the story, but she celebrates the 3 enslaved women that he practiced on. She went a step further and redid that painting in the cheekiest way. She also bought the land where J. Marion Sims practiced, and she's building a women's clinic and a museum. It'll be open, she told me, next year. So now there's like a few more reasons to go to Montgomery, Alabama, which is actually it's one of my favorite places, partially because of the activism that's coming from there and the really beautiful storytelling through museums. But it's really worth seeing the sculpture garden and seeing this painting in life. And here are my pre-med students. These are CUNY, the City University of New York Medical School. its mission is to train the doctors that will return to the community to practice. And these were my students 2 semesters ago, and they were wonderful. Their hearts are in the right place. I hope they're gonna stick to the plan to go back to the communities as they promised, to get all their training right at the City College of New York, at CUNY Medical School, and go back and practice in the communities that they care about. And this slide is my last one because it's the hope and it's the future. Thank you.
Wow. So now we're going to have an opportunity to hear 2 responses to, can I call you Linda?
Yes,
yeah,
please.
Is that all right? It's the Professor. Yeah. 2 responses to Linda's incredible address to you all. First of all, it's going to be Professor Delan Devakumar. Delan is a Professor of Global Child Health and co-director of the UCL Center for the Health of Women, Children and Adolescents. He's also the chair of a Lancet Commission, which I'm very pleased about, Lancet Commission on Racism and Child Health. And he's also the chair and founder of an organization called Race and Health. And then after Delan, it's a great pleasure to introduce Dr. Rochelle Burgess, who's with us. Rochelle is an associate professor of global health and deputy director of the UCL Center for Global Non-Communicable Diseases at the Institute of Global Health here at UCL. She's also the founder and director of UCL's Global Network on Mental Health and Child Marriage. So Delan will go first for 5 minutes, and then Rochelle, and then we're going to open it up for a discussion. So Delan. Yes, why don't you do that? That would be great.
So thank you very much, Richard. And firstly, I'd like to thank Professor Linda Villarosa for such a wonderful and engaging talk, but also distressing and difficult talk as well. Racism towards black people in the United States is a profound health risk and is clearly one of the most important determinants of health and something that we as health professionals and academics need to prioritize. Linda's presented the US situation so well, and in this response, I'll talk a little bit more about the UK and other contexts, and then Dr. Rochelle Burgess will speak to solutions and lived experience. The argument that I've made through our academic work is that racism and xenophobia and similar ideologies are present everywhere. These racist ideologies lead all the way from microaggressions on one hand to war and genocide on the other. People are divided up into groups and then a hierarchy imposed based on race, on ethnicity, skin color, caste, religion, indigenous status, migration. We are different to you, then we are better than you. You don't have the same rights, you don't deserve the same rights. These are the reasons that lead to the health consequences we see. The numbers in the United Kingdom, the numbers in the US are mirrored around the world, and the UK, with a very different health system, has the same or similar health inequities. In COVID-19, racial and ethnic disparities came to the forefront. In the first and second waves, the ethnic difference was seen. Bangladeshi women had 4 times the risk of dying than white women. Bangladeshi men 5 times the risk of dying than white men. But this isn't just about a pandemic and unusual circumstance. This is all the time. If we look at the youngest individuals in our society, they're born with that disadvantage. The National Child Mortality Database shows that the mortality of Asian infants is more than double that of white infants. Of black infants, it's nearly 3 times higher. And in terms of illness, infants are born with low birth weight, less likely to breastfeed. Children, there are significant associations with depression, anxiety, low self-esteem, asthma, malnutrition. numerous, as Linda described, numerous health outcomes. But I want to pick up on one of the determinants of health that you mentioned, climate change and structural racism. You described how Black Americans are more exposed to environmental pollutants, and we have that here in London. A report from the Mayor of London showed how pollution is patterned, with ethnic minorities, on average, breathing different, more toxic air than others. And this is a similar situation around the world. Those who contribute the least face the worst consequences, the poorest minoritized populations in the global south, the indigenous communities around the world. My colleague, Dr. Priscilla Sato from Brazil, described how Quilombola communities, who are the descendants of enslaved African people brought over to Brazil, are adversely affected by climate change, leading to almost half being highly food insecure. In the Brazilian Amazon, land disputes are intensified by mining and agribusiness, and these have increased deforestation, increases in the dry season, the risk of fire, ecosystem stress, all leading to crop failures and resultant health outcomes. And the second thing I want to touch on is the power of stories. Racism is a very personal thing. Verbal attacks, physical attacks, the fear of abuse, the loss of a loved one. And throughout her book, Linda weaves through these personal stories with the evidence, the facts, and the figures. I want to describe one of the most powerful stories, and that's the story of race and racial difference. This goes back to the 1700s, to the likes of Karl Linnaeus, Johann Friedrich Blumenbach. These ideas on how to classify people are not biologically based, but based on their own opinions, their thoughts. They attach characteristics and behaviors to what someone looks like. And these stories have been remarkably successful. They've remained throughout the centuries. I also think it's poignant to look at a derivative of these stories, and that's the story of eugenics, a term coined by Francis Galton and followed on by Carl Pearson, both from UCL. Eugenic attitudes permeate throughout science and medicine and can result in some of the greatest atrocities. The recent UCL inquiry into eugenics considered the consequences, and I quote, "Around the world, eugenics of one form or another is implicated in compulsory sterilization, legislation on mental deficiency, immigration law and racist policies, the notion of natural intelligence, normalization of segregation by race, ability, and class. Forced sterilization was designed to reduce poverty, to reduce the gene pool. But also, as Linda writes, the opposite also happened when enslavers forced Black people to have children to ensure the supply of labor." And it's important to talk about this. Again, the UCL inquiry. UCL must confront its role in eugenics by understanding the past. The past should not be hidden, but openly and critically discussed. It should be talked about more, not less, in a way that restores agency and visibility and dignity to its targets. So finally, we know the stories are powerful. The counter to these stories of racial hierarchy are positive stories, stories of how people can live together, how we can reduce negative consequences. Research evidence is needed, and narratives are often set in opposition to the evidence and research. But to tackle racism, we need evidence, and we need stories together to act at all levels, from individual to structural. And this requires health professionals and academics, but it importantly requires all of you as well. Thank you.
Thanks, Dylan. And I just want to echo my deepest thanks to you, Linda, for the gift that is your book. I grew up reading Essence, so this is like huge for me in so many ways. In Canada, like, we didn't have an Essence, so like it was, yeah, I'll stop fangirling in that context. I, of course, agree with Dylan about the importance of work like this, which puts into such clear and accessible framing the most difficult and long-standing challenges that face communities globally today, that of racism and its long-standing influences on the bodies of Black and other minoritized peoples of the world. And we're gathering this evening at a time when we can see so clearly the necessity of stories that cut through the noise to remind us of the necessity of naming violences that are disproportionately waged against minoritized people in Gaza, the DRC, Sudan, in Brixton and Hackney and Wandsworth, in every corner of the world, stories that drive us towards unending quests for justice that must be achieved in order for any hope for good health to be possible. And so I want to reflect specifically on how your storytelling pushes me towards not only stories of my own, but the importance of stories that imagine what next, as that has always been a preoccupation of mine. I'm a community health psychologist by training, which I've always described as essentially being an activist in academic clothing, like blazers. So while there is a necessity to understand scale and scope of a problem, there is a necessity for mapping routes to ending these problems alongside that. And your work for me highlights so clearly the working of reproductive injustice and obstetric racism and obstetric violence, at a time in my life when it feels very, very hard to be reminded of them, the salience of it. It's heavy, it's to borrow the word, it's weathering. But as a Black feminist, I'm also simultaneously drawn to the flip side of this coin, reproductive justice, or the role more broadly of justice as it relates to the necessary work of understanding what's next. And these concepts are dealt with really beautifully in the work of Dana Ain Davis, who I know you know well. And I'm drawn specifically to how she talks about reproductive justice and how that aligns to how you speak about the need to put care back into healthcare within your work. In an interview that Dana gave around the time of the overturning of Roe v. Wade, she describes justice as it relates to both a moral and ethical rightness, about equity and the importance of having all of the social and economic support that people need to live life with integrity. This and your work really resonates strongly with what I think about in my own work around mental health and social justice, as the importance of developing logics of care that are oriented towards repair. And so by repair, I mean the necessity of developing frameworks, systems, and services that see the work of care as an antidote to violence. Repair that seeks to right the wrongs and cracks in systems, in individual psyches, and of course their intersections, where violence is often enacted. And in your chapter on care, you point towards the critical role of community, specifically community health workers, and very long traditions of primary health care, and what this role that could play in sort of leveraging this type of care. And it also draws my attention to the ways in all the different other registers where care work could happen and is happening. And ultimately, the role of activism and advocacy as a necessary part of repairing social ills and acts of care. I often find that my work of activism is very much like a very clear and welcome response to the way that weathering sort of works in my body and in my life. The beauty of having a space to imagine otherwise and what that enables. But what also strikes me is that none of this is new. So, talking in your chapter about care and Alma Ata and barefoot doctors, all of this has been discussed for decades. And social movement work around all of these issues has been going on tirelessly for generations. And here we stand still fighting the same battles. And so I think, and in your talk, you really reflect on the importance of what we teach to next generations and how practitioners and students are embedded and emboldened, not just with a knowledge of differences and challenges, but also an awareness around solutions and survival, orienting us towards the way people survive every day in small scale and large scale ways, and how that over time, supporting those processes contribute to the achievement of worlds where people are able to live with dignity and integrity. And so in the UK, this makes me think specifically about the spectacular work of the 5 Times More campaign around Black maternal health inequalities, and the amazing work that this collective has done in the span of just 3 years to put power into the hands of Black women and Black birthing people in the UK by working at multiple levels of systems. So not just thinking about the health system and how we sort of build partnerships and engage with trust to sort of build new systems for response, but also simultaneously working with Black women and birthing people and families, creating safe spaces for dialogue and reflection, the importance of parliamentarian action and policy work. And I just really felt that it's important to acknowledge that within these sorts of narratives are many stories of survival. And last week was Black Maternal Health Awareness Week in the UK, and they had a specific day that was devoted just to positive storytelling. And I really think that that sort of multi-tiered, multi-leveled action does have gains and does see gains. You know, this is my second child. I'm due to give birth, not eminently, don't worry, soon enough. And I've been engaged in that landscape at two very different time points, just 6 years apart. And I really feel that there is a palpable difference that has happened through the activism and the collective work of this movement in changing my trust, which is outside of London, and creating a space for issues to be discussed and spaces to be created to acknowledge these challenges. So, you know, progress is possible, and I'm glad that you ended your talk with the faces of these young, brilliant people who will go out and continue to build the future world. And I just really wanted to thank you for not just the book, but the ending of the book, which I felt was really important in reminding us that change is always possible, and the world that we envision is still within our reach. So thank you very much, and I will stop there. Thank you.
Thank you very much, Rochelle. Before we start the Q&A, I would just like to acknowledge the Lancet's complicity in the history that Linda has been talking about this evening. If you go back and look in the archive of the Lancet, you will find articles, 6 articles, by J. Marion Sims in 1865, in which he sets out what he calls clinical notes on uterine surgery. And to understand that much of that work will have been based on the kinds of practices that you described this evening is an appalling reality to confront for our generation of editors at the Lancet. So thank you for drawing that to our attention, but it means and puts even greater responsibility on us to confront that history, to acknowledge it, and to do something about it. So let me talk about, let me come to some questions. And we've got questions from the audience, but I have a few that I'd like to kick off with. Linda, you're so optimistic, and it's really hard. On page 166 and page 212, I wrote down that you said, I remain optimistic. And it's hard to see how you remain optimistic given the stories that you've told. One particular argument you make is that even though there's been report after report after report describing what you have set out this evening, they have failed to trigger any significant action. And you write about, in your words, the void of government response. We can't wait for another 10 or 20 years for a new generation of young health workers to change the system. We need to do something now. We have a presidential election in your country. What needs to be on the agenda for the next president of the United States? If you could be in front of Mr. Biden, President Biden, and the other one, what would you tell them to do?
Oh my God, okay. I think I would keep it simple and tell them to listen to people. And I think what we do is we need evidence. We keep saying we need more evidence, we need more evidence. I'm like, no more evidence, just listen to people. People, I mean, evidence is an accumulation of what people are trying to tell you. And it was really my daughter who said that, because she said, well, who is your book for? And I said, oh, it's for politicians to make policy changes, and it's for medical students, so they'll be emboldened, and it's for medical, college administrators and faculty. And she said, it also, you need to really think it's for real people to both lift up their experiences because they feel that it's their fault when they get ill or they're treated badly, and so that also they can feel power, the power of talking about what's going on, what has happened in order to change. And I think listening to patients and listening to their experiences and also listening to their own solutions is really important. It's something we don't do a lot, even at places that are very moneyed. We're just using evidence without saying, wait, let me hear what people think the solution should be.
So listen to the people.
Yeah.
So Rochelle and Dylan, we're going to have an election probably this year. So what would you like to see in the manifestos of our political parties to address racism in healthcare and health?
This is live, right? Daylon, over to you.
I mean, well, one of the simple things is just to stop demonizing people. That's prevalent throughout political discourse. And it's obvious and overt, and it's terrible. It leads to the consequences that we see. It leads to these racist ideologies permeating through society. So it's very simple. Within the health system, we can stop charging migrant groups. We can try to reduce the barriers that result in the health inequities that we see. We can educate health staff, educate doctors, going back to medical school, to their training. But really, I think there isn't that quick fix. It isn't about stopping things now. Going back to medical students, we still have your slide ahead of us, but I think it has to go back much further. We need to go back to primary school. We need to talk to children. We need to educate children. Some of the best interventions, US intervention on early child development, was this big, widespread intervention that looked at lots and lots of different things. And those are the ones that have the best health outcomes when we're looking 10, 20 years into the future. So I'm sorry, I don't have a quick answer for you.
No, that's great. Rochelle.
I've relaxed enough to be able to answer the question. I think for me, what I would like to see is sort of a renewed agenda around transfer of power to communities around health. So there is legacy of that here. The favorite thing of every government I've been witness to in my time in the UK is they like to spend time reorganizing the NHS. So every time there's new reorganization, it gives everybody a project. It's really nice. And every time they do that, there is a new sort of vision or role for community actors. And oftentimes that role does not come with access to resources to put things into action. And when you go to communities, it's this point of listening to people. People know what the drivers of their poor health is. They know what the solutions are. They lack sort of systematic and structural power to put those solutions in place. So there are models all over the world of how we can think about that devolution of power to communities, to organizations, to sort of enable their access to drive their own health responses. And I think that would be not a fast fix, but sort of more of like an interim fix. But I guess social change happens along these continuums, right? So you need to have a government who is able to say, this is gonna take 10 years and I'm okay with that. Even though my re-election is coming up in 5 years, I want to invest in something that will take 10 years to show a change. And that is my legacy. One of my favorite Canadian politicians, Jack Layton, who passed away many years ago now, used to say, you have to have a dream that's longer than your lifetime. And I think that's such a beautiful way of thinking about sort of the legacies of what governments leave behind, but in a positive way. So having that long vision to say, I'm going to invest in Sure Start programs or start them up again and let them run for 10, 15 years and earmark this money for nobody can touch it, or I don't know. Yeah, I'll stop.
That's great. Thank you. Now, I've got lots of questions from the audience. So some of you prefer to be anonymous, which is great, and some of you have disclosed who you are, and I will disclose your names when we get to you. You mentioned, Linda, that it may be time to change the phrase social determinants of health. Explain a little bit more about that and what you would like to see it be better phrased.
Well, no offense to anyone here, but I think when I say that in audiences of, community people, they're just blank. And what is that? And then you have to say, well, it has to do with where you live and where you play and where you pray. And a lot of the writing I do and a lot of the speaking I do and interactions are with people who are suffering from things but don't have the language always. I try not to speak in jargon hardly at all. Some of the jargon I don't even know. And so I think that might be an interesting tweak to say, what do we really mean by that? And I mean, I know what it means, and I know the effect of community, what's happening in your community, knowing from where my mother was from. But I think, if you say to people, people are blamed for you don't eat well. And it's sort of like, well, the grocery store is terrible, and the vegetables are brown and the meat's green, if they're, or it's not even existing, and that's a social determinant of health. So we just have to maybe not change the name, but maybe explain it.
Yeah. Another anonymous questioner. You made a provocative statement at a university that we don't need any more evidence. So what's the purpose of all of us? For those of us who work in research and academia, what should we be doing every day?
I want more evidence, but I don't want us to keep saying that we don't have evidence of discrimination and ill treatment in the healthcare system, that we need more of it. There are lots of things to study, and we want to continue to study that, but I think we can take, I don't want people to say the lack of evidence is keeping us from taking action, from making change, from doing something. And I think that has happened too much, where we're admiring the problem but not trying to solve it, or we're saying we just need to work on it more.
And the questioner is asking also, so which directions, from your perspective, do you think we need to go in?
I think that the most important research is the research where people are included from the community in the research project. So whether it's community co-design, and I have sat in on some really beautiful sessions where healthcare providers were really listening to people, where there was someone from the community on the commission, where the meeting wasn't taking place in the hospital or in the clinic, it was taking place in the community, so that you had to leave the ivory tower and go to the community and see where people are. And that was thrilling for me. I really love the community health workers, partially because they are in people's homes. So they are seeing the community. Even as a storyteller and a journalist, I don't do any reporting at all in a place until I know that place quite well. And I have zero sense of direction, so I am always lost and driving around and wandering through the community. So I know communities very well where I'm going to report before I ask a single question.
Very good. Rochelle Dillon, what do you see as the role of the university community in work of anti-racism?
Can't ask Dillon to go first twice. I think the role of the university is one to make space for the relationship between activism and scholarly pursuits. I think there is, and it feels very dangerous to say it, but I think that was very much the tradition that I sort of imagined academia to be, that I sort of grew up watching it in. And I think particularly when you're working around issues of inequalities like racism, and I think we can't step away from the fact that, the ivory tower, what it also is sort of this, like, these bastions of power. So when you're inside the ivory tower, that actually gives you a proximity to types of power to open up spaces for dialogue and opportunity and to change things, to create space, to make space for new ideas, for, I think the phrase that we use at UCL is disagreeing well, which I really like. I think there is a necessity of actually being able to sit with someone that you don't automatically agree with and to figure a way through. Now, who does that labor is very important, and it's probably the space for a whole other talk and maybe a whole other book. But I do think that there is a special role that the university does hold in creating and making space for that. And so I don't think you can be an academic around issues of racism and inequality and not have an eye towards the importance of activism and speaking up and creating space and making space for that.
Very good. Dylan.
Thank you, and I would echo those thoughts. And the work with communities has to be part of the kind of research we do. Just one point on the evidence, that there's a lot of evidence from the US. Evidence on racism is nearly all from the US. Mm-hmm. There's actually very little around the world. I mean, the UK there is, but in other countries, very little. So we often don't know who the communities are who are worst affected. We don't know lots of that. But also evidence for action. What do we do? How do we do it? How do we get those systems to change? What works and when does it work? Where does it work? So try to understand in more detail those kinds of interventions. And then also to your point, Rochelle, UCL universities are ivory towers, but they don't have to be. There can be public events. There can be events that we talk to people, we engage with people, we engage with different populations, we invite others into the university, into the space. So we can break down that ivory tower.
Mm-hmm. The university is a social institution. It serves society. Hazel Smith, I don't know where you are, but thank you for your question. Given the long history of racism on the harm on health, can the damage be truly undone? And even if we have equity tomorrow, will we see equal health outcomes?
No, it's the damage is long and old, and it's not like there's a ton of action happening right now. There's especially, I can speak most about my own country. We're starting to get so much pushback against these ideas, and it's swinging backward. Depending, it will be the same, slightly better, or much, much worse, depending on who our president is. And what I just hope is, this discussion we're having about what action can you take locally, and that really matters, and that will make a difference. It might, depending on what happens in the country as a whole, what individuals' communities can do can be the most powerful, and also the most kind of involving people more as much as possible.
Very good. Rochelle, Dylan?
Yeah, just really the point on communities is really that's it for me, because communities are longer than governments. The spaces that we build and the movements that we create locally often sort of exist through multiple iterations of who's in charge at the wheel. And I think there's this phrase that I love from when I was doing my master's, which is coined by Sandra Jevcelovich, who's a social psychologist, in some of her work in Brazil. But it's this idea that health is lived. So if you can create, even at a very local level, opportunities to build and grow and joy, and sort of really turning towards those examples where people sort of negotiate survival and good things through the difficulties, I think that there's a lot of seeds there for what we can grow from the bottom up. And we sort of can find the cracks within whatever system we're in, because people always have and they always will. That's why we're still here. So yeah, I think for me, just really sticking with community through all of that becomes a necessity.
I think the question was, can it be undone? And if it stopped tomorrow, things would carry on. So the short answer is no. But longer term, yes. If we want to be positive about this, so I work on child health, and you can make changes, and it might take a generation or 2 or 3 generations. And our children are facing lots of threats and problems on the horizon. But if we want to be positive, the types of people you work with, the young medical students, we can make change, but it's a longer horizon I think we need to look at.
All of you talked about activism, the space between activism and scholarship, the role of the next generation. So now you have a direct question. What advice do you have for young academics who aspire to make a difference in the real world? Who'd like to go first with that one? Go on, Linda.
Okay. Well, it's so interesting. I get so inspired when I see an example of it. I talk about that Institute for Healing and Justice in Medicine. They started in 2020. It was medical students at the University of California, San Francisco, and they were getting a dual degree at Berkeley, their MPH. So they took a class that was kind of, about racial health inequalities and disparities, and they got on fire. And it was only about 6 or 7 of them. And they went back to their dorm and they said, we need to start this group to have medical students speak amongst ourselves to make sure all medical students get included in their education these kinds of discussions. So someone told me about them, and I included them in my book, and I called one of them, and I said, wow, you guys are doing such great work. I see that you have an address. Do you have an office? Where is that? And they were like, oh, that's our student lounge. And then I'm like, does the school give you money, either of the schools? Yes. I said, how much? $600. I'm like, well, that will pay for pizza. So these students mobilized through social media, through their digital means, 3,000. They had a launch with their little $600 and in their student lounge and their social media. And they have these discussions, which are very interesting. And they do actions. They talk about what they're doing. Because they're a couple of years old, they've had graduates. One of them came and spoke to my medical student class, and it was so exciting for the students to see this physician standing in front of them, talking about how she was involved in starting this organization. She's taking it to the next level, and and speaking to other groups. And I just thought, that's what we want. An idea that is not driven by money, it's driven by energy, and and these are people who are, medical school's hard. They're in medical school still organizing themselves. If they had even a bit more support, I think it would be even better. But I was just really inspired and proud of them for what they did. And that's a specific action that worked, that they could do on their own, basically.
Very good. Dylan?
Yeah, this needs to be built into curricula. So, just thinking about when I was in medical school, I think we were quite radical that we learned about sociology. That was unusual. I don't remember hearing what public health was. I don't think that was a thing then. But that's changed. There are more of those discussions happening within medical school curricula, but there's still so much more it can go. We spend so much time on anatomy, on physiology, on things that I really can't remember anymore. Yeah. But we don't talk about the big problems in the world, the big determinants of health, going back to that phrase, the big things that will shape the health of populations. And we really should spend much more time on those things.
And I guess the only thing I would add to that, which just still feels related, is the importance of finding your people. Because, med school is hard, life is hard, activism is hard. And there is something about sort of navigating those journeys collectively. And I imagine, the joy of seeing a practitioner sort of standing in front of you who speaks the same language as you about the world and how you want it to be and what it should look like is galvanizing. And so those opportunities to find your people and to start with an action, no matter how small. Those are the things. So you have to think about change as something that will build and grow, even from like the smallest step. I think when I was younger and in my peak sort of activism days, I was always very quick to be dissatisfied. And dissatisfaction keeps you moving and going in a lot of ways, but it can also be something that dismotivates you. And so there really is an importance in that regard of finding people who, you know, are going through that with you, sort of to move along in that journey together. Yeah.
Very good. Now, this system that we're using for questions is called Slido, and what it does, it not only tells me the question, but it tells me how many of you have voted for that question. And the most popular question, people are a bit worried about you. So the most popular question is, how do you continue to stay healthy while doing this work?
Aw, thank you. Good looking out. I am like my father. I really like fishing. The fish I caught last week, right before I came, all by myself in my boat. I had to land the fish and get it in the net, and then clean it, and then give it to my mother. So she loves fried fish. So I am really outdoorsy. I also have a really good social network. I have friends that I can talk to. I have a really cute dog and a little naughty cat and a partner and 2 wonderful children. Okay, and I also play all gender intergenerational soccer. I am really competitive, though not as good as I am in my head, but I play on Wednesday in our little league. And so I get a lot of physical exercise and also have a lot of social connection. And I think I also am kind of good at this. I'm a person who's really passionate, but I don't bring it into my soul. I put it on the page.
Very good, very good. Now a question from Sarah Dalgleish, and that is, what are the most important ways that non-racialized white people can combat these problems?
Well, I think believing your Black and people of color friends really helps. Supporting your people, supporting these ideas and issues. Also, I think some of the solutions that we come up with are need to be thought through better, / ask people what they need rather than imposing it. And I remember there were some really good Congress people that were looking at the maternal mortality crisis, thinking about it and trying to solve it only at the hospital level. And it was like, uh-oh, you didn't really talk to anyone. You were just thinking, okay, mothers have babies at hospitals, so that we'll just fix these hospital problems. But then, as we saw from California, it didn't narrow the racial health gap. So I think for everybody, and all people are part of this. And in my book, I talk about talking to my friend Steve. And I was talking about Black health problems and racial health disparity. And I was saying, our problem, our people, our solution. That's what I said to him. And he looked at me and he said, this is not your problem, your people. It is your people, but it's not you're not responsible for the solution. Everyone needs to be responsible. This is our country. No one should be discriminated against in the country. No one should be suffering from ill health because of it. And it's a national problem, and it causes, it calls for solutions that all of us need to work at international problem, and we need to work together, not in our silos.
Very good. Any quick additions?
I had a conversation recently about work on violence against women, and there were parallels there. It can't just be left to women to solve the problem. Men have to be involved. So I agree. It's the whole society.
Before we go to the provost, who will have final words, I have one last question. There are some real medical monsters in your book, and we've mentioned a few of them: Samuel Cartwright, J. Marion Sims, Benjamin Rush even. I didn't know Benjamin Rush was tied up in that, but he gets a mention in the book as well, unfortunately. I wonder, what do you think those in the future will say about us?
I hope they notice that I got a new suit for this talk. So, I do think about that. I think about, like, part of the reason I put in my book that I started here and I ended up at a completely different place. The first chapter is called Everything I Thought Was Wrong. And I think it's important to admit mistakes and admit going in the wrong direction and be open to finding new solutions, to listening to people, to thinking through, maybe what I thought before wasn't right. And so I hope that part of my own personal legacy is that I was a person who changed my mind because of listening to people and figuring things out and not just sticking in one, mode of thought. And I hope that that's, how we all think. And, and it's humbling, actually, to admit, I was wrong. I was quite wrong. And I had a lot of power, and I was wrong. And I just switched and changed, and through personal experience, through listening to people, I changed. That's a really good one. It's really hard to think, what will they say about it? I mean, I sometimes think that the next generation, my kids will look and say, you weren't radical enough. That's what I feel that I sort of my
might
kids
hear.
already say that to me every day.
And I can sort of, I hear it, and I think that maybe there's something in it, but I think also, in that sense, I am drawn to the work of Deepa Iver's social change ecosystem, and her work around sort of the different roles that we all play towards moving the needle and sort of building a better world. And there are storytellers, and there are people at the front lines, and there are many different ways in which we live our activism. And so I hope that in the future they will see the ways that all of this work collectively contributed to moving the needle, and to remembering that it's only through action on all these different levels and all these different points that is what moves change. So, yeah.
So the pessimist in me thinks that things will stay the same. So they will say this is the same as it is for them. The optimist in me thinks that they will look back on this time and they'll be confused. Why did you live in this kind of society? Mm-hmm. So I'm hoping for that optimistic view.
Please give the panel a warm round of applause.
So, Dr. Villarosa, it's my great privilege on behalf of UCL to move a vote of thanks for you for an incredibly challenging and inspiring and difficult and important lecture. This is also the first outing of a new suit, I'm glad to say. Although I have to say, when you listed your recreational activities, I felt inadequate in every way. But as I was listening to your lecture, and then listening to the conversation with Professor Devakumar and with Dr. Burgess, two themes kept coming back that I think are a challenge for us as a university and that were fairly consistent. The first was the systems of oppression are incredibly sophisticated in the modalities that they use to operate power. So there was medical technology, there was medicine itself, there was humor and comedy, there was storytelling, there was history, there was philosophy, there was social planning, there was spatial planning. In fact, almost everything that the university works on was there in one way or another, keeping people down. And the philosophy of the grand challenges is that actually it will take the whole university and all those resources again to think about how we might bring about change. And it was inspiring to see the way that you were able to trace so elegantly that system of oppression and at each point raise a challenge for the kinds of disciplines that we work on. The second thing, and I think this comes to some of the disagreeing well stuff that Dr. Burgess was alluding to, that I think is particularly challenging for a university community, is that so many of these people thought they were doing good. So many of these people thought they were changing the world for the better, or at least doing no harm. And that's why I think Dr. Horton's question about what will people think of us in the future is so searching. Because it's epistemic humility. It's the capacity to do the kind of reflection that says, what is my intellectual practice? What is my professional practice? What are the values that are shot through the ways that I work? And how does it either treasure people and promote human flourishing or dehumanize? How is it either human or, in the words of Dr. Martin Luther King, inhuman? And I think if we keep together that capacity to think across the discipline and that constant process of self-reflection and that cultivation of epistemic humility in our students with the kind of activist fire that was so evident this evening, well, then I have a little bit of hope for the future. And so thank you so much, Dr. Villarosa, Professor Villarosa, for an incredibly inspiring lecture and for a challenge to us in so many aspects of our work. Thank you to Dr. Horton for the partnership with the Lancet, of which the university is incredibly proud.